Hello and welcome. My name is Sarah Cutchin, and I am the Partnership Lead on the Adolescent Immunizations Communications team here at CDC. And so we are very excited that you can join us today for another preteen vaccine webinar entitled HPV Vaccine Schedule Change Update, What It Means and How to Implement Today. Before we get started, I just have a couple of housekeeping items to go over. First of all, I just want to remind everyone that your lines have been muted, so please don't put your phone on hold, and if you need to step away, feel free to hang up and dial back in when you can. So we'll have a Q&A session after the presentation, so as you have questions, please go ahead and type them into the chat panel. This panel is in the lower left-hand corner of your screen. And since we have multiple speakers, if you can please indicate who your question is for and who to direct it to, that would be awesome. So then when we do get to the Q&A part, we'll read the questions out loud for the speakers, and then they can respond to everyone. So as I mentioned before, we have quite a few speakers today from different areas of CDC. So we'll be discussing a few different aspects of the HPV vaccine recommendation change, like how the decision to change the recommendation came to be, how this might affect programs, and then how to talk about the recommendation change. But first, we're so excited. We'll be hearing from Dr. Nancy Messonnier, the Director of the National Center for Immunization and Respiratory Diseases here at CDC. And so Dr. Messonnier, the floor is yours.
Great, thank you, and good morning, everybody. I'm really happy to be here today and actually really excited to look at the list of how many people are participating in this conference with us. It's a great sign of the fact that you all think with us that this is a really important topic. I want to start by thanking all of you. We truly appreciate all of the hard work that you've put into improving our HPV vaccination rates. I know, though, that you, like I, wish those rates are higher and are committed to trying to get more kids vaccinated. Preventing cancer just got easier with the HPV vaccination schedule change to 2 doses. It's actually really unusual and gratifying to make it easier for completion of a vaccination series. We want to use this opportunity to re-engage parents and especially to re-energize clinicians about preventing cancer with HPV vaccine. We can encourage parents to vaccinate their kids at the recommended ages of 11 to 12 by just getting 2 doses of HPV. The 6 to 12-month interval between those doses will also make it easier for parents to schedule appointments to complete the series. We want to work with you to support parents in completing the HPV vaccine series with reminder systems, open scheduling, and standing orders for nurse-only appointments. This is a really important topic for me and for us, and I really encourage all of you to continue to be HPV vaccine champions and to lead the conversation with your colleagues and peers. Thank you very much, and I'll pass the microphone back.
Excellent. Thank you so much, Dr. Messonnier, for that and for taking the time to join us today. So next we'll be hearing from Dr. Lauri Markowitz. She'll be sharing some background information about the ACIP. Dr. Markowitz, please go ahead.
Okay. Could you hear me?
Yes, ma'am.
So this morning, good morning, everyone. This morning I'm going to review the updated HPV vaccine recommendations and also review the considerations by ACIP that led to this recommendation change. I think that most people know the first vaccine was licensed and recommended in the United States in 2006. And since then, recommendations for HPV vaccination have evolved based on additional data and considerations. And over the past year, ACIP had reviewed data on 2-dose vaccination schedules. And in October 2016, ACIP voted to recommend a 2-dose schedule for adolescents initiating vaccination at age 9 to 14 years. And what I'm going to do today is briefly give a background on HPV vaccines, then provide a summary of evidence reviewed by ACIP and CDC for the 2-dose schedule, then review the updated recommendations themselves, and end with a few case examples. There are 3 vaccines licensed in the United States, the bivalent, the quadrivalent, and the 9-valent, and these vaccines are all virus-like particle vaccines composed of the L1 major capsid protein of the virus. And while they're all virus-like particle vaccines, they differ in the types they target, as shown in the first row, in the production systems and in their adjuvants. And the first vaccine was the quadrivalent vaccine licensed in 2006, and the most recent vaccine was the 9-valent vaccine that was licensed in 2014. Now, HPV vaccine use and availability in the United States has been changing. Through 2014, almost all vaccine used in the United States was the quadrivalent vaccine. And in 2016, almost all HPV vaccine used was the 9-valent vaccine. And after the end of last month, only 9-valent vaccine will be distributed in the U.S. Bivalent vaccine and quadrivalent vaccine will continue to be available outside of this country. The HPV vaccine data reviewed by ACIP in 2016 for the 2-dose schedule is outlined here. In February, ACIP reviewed immunogenicity data from the 9-valent 2-dose immunogenicity trial, as well as results from 2-dose trials of bivalent and quadrivalent vaccines. Then in June, ACIP reviewed cost-effectiveness, impact modeling for 2-dose vaccination, data from effectiveness studies, and duration of protection. And the formal grade process that ACIP uses for evaluation of evidence was also presented. And then in October, all of the data that had been reviewed by ACIP was again summarized. There were proposed recommendations and a vote. I want to discuss briefly the immunogenicity data on 2-dose schedules that provided much of the evidence for the updated recommendation. Immunogenicity trials comparing 2 and 3 doses have been conducted for all 3 vaccines. And the main analysis in these trials were comparisons of the antibody response after 2 doses in young adolescents about 9 to 14 years, with 3 doses in young adult women about 16 to 26 years. The comparison group in these analyses is the age group and the vaccine schedule for which efficacy was demonstrated in large randomized controlled trials. These immunobridging analyses are used because although the basis of protection after vaccination is thought to be neutralizing antibody, there is no established minimum antibody threshold for protection. Trials of all 3 vaccines found that the antibody response after 2 doses given at 0, 6, or 0, 12 months in the younger age group is non-inferior to the antibody response after 3 doses in the older age group. And I just want to show 2 slides of some of the data from the 9-valent 2-dose trial. This particular slide shows the antibody titers, shown as the geometric mean antibody titers for each of the 9 types. And the 2 groups compared in this slide are the group that received 2 doses at 0 to 6 months at age 9 to 14, shown in blue, and women who received 3 doses at 16 to 26 years, shown in yellow. And the geometric mean antibody titers in the girls who received 2 doses at 0 to 6 months were non-inferior to those in women who received 3 doses at 0, 2, and 6 months for all 9 types, as you can see. And the antibody titers were in fact significantly higher at the younger age. This is another analysis from the trial. Here are shown a comparison of 2 groups, girls who received 2 doses, girls and boys who received 2 doses at 9 to 14 years at an interval of 0 to 12 months, shown in blue, and women who received 3 doses at 0, 2, and 6 months, again here shown in yellow. And you can see that the geometric mean antibody titers are not only non-inferior but higher in the younger age group that received 2 doses for all 9 types. Given that individuals in the U.S. have received bivalent or quadrivalent vaccine and some did not complete a 3-dose series, ACIP also reviewed available data for bivalent and quadrivalent vaccines. 2 trials of the quadrivalent vaccine and 3 trials of the bivalent vaccine compared 2 doses in the younger adolescents with 3 doses in the age range in which efficacy was demonstrated in clinical trials. And these studies also showed high seroconversion seroconversion rates in all vaccinated groups and non-inferior antibody titers. These studies had longer follow-up time than the 9-valent trial, 60 months for the bivalent and 36 months for the quadrivalent. So in summary of what I just reviewed and also some other data reviewed with ACIP that I have not summarized today, although there are 3 vaccines licensed for use in the United States, after the end of 2016, only 9-valent vaccine will be available. Immunogenicity trials, all HPV vaccines found the antibody response after 2 doses at 0, 6, or 0, 12 months in 9 to 14-year-olds was non-inferior to the response after 3 doses, the age group in which efficacy was demonstrated. Data from the 9-valent 2-dose trial were submitted to FDA. In October 2016, FDA approved 9-valent vaccine as a 2-dose series for persons aged 9 to 14 years. Post-licensure effectiveness studies were also reviewed by ACIP. Studies examining HPV vaccine effectiveness by number of doses are difficult to interpret at this time in the vaccination program. Data from follow-up of 3-dose vaccine trials show the duration of protection after vaccination is long-lasting, and antibody data suggests the duration of protection will be the same after 2 and 3-dose schedules. And finally, ACIP used GRADE to evaluate evidence on 2-dose HPV vaccination schedules and made a Category A recommendation for a 2-dose schedule for persons initiating the series at age 9 through 14 years. So now I would like to review the updated recommendations, and I will review briefly recommendations in these 5 categories on the following slide. So the routine and catch-up age groups for whom HPV vaccination is recommended has not changed. ACIP continues to recommend routine HPV vaccination for girls and boys at age 11 or 12, and vaccination can be started at age 9 years. ACIP also recommends vaccination for females through age 26 years and males through age 21 years who are not adequately vaccinated previously, and males age 22 through 26 may be vaccinated. And I'll mention the special populations and medical conditions later. The new recommendations for HPV vaccine dosing schedules are: for persons initiating vaccination before the 15th birthday, the recommended immunization schedule is 2 doses. The second dose should be administered 6 to 12 months after the first dose for a 0, 6 to 12 month schedule. And for persons initiating vaccination on or after the 15th birthday, the recommendation for a 3-dose schedule remains. As before, the recommended schedule is 3 doses. The second dose should be administered 1 to 2 months after the first dose, and the third dose should be administered 6 months after the first dose for a 0, 1 to 2, and 6 month schedule. Again, as before, ACIP recommends that if the vaccination schedule is interrupted, the series does not need to be restarted. A new clarification is that the number of recommended doses is based on the age and administration of the first dose. ACIP already recommends catch-up vaccination through age 26 for men who have sex with men and for immunocompromised persons, and has clarified that this group further in the updated recommendations, and also mentions transgender persons. ACIP continues to recommend HPV vaccination for immunocompromised persons aged 9 through 26 years with 3 doses of HPV vaccine. Persons who should receive 3 doses of HPV vaccine are those with primary or secondary immunocompromising conditions that might reduce cell-mediated or humoral immunity, such as HIV infection, and other conditions that are listed here and will be also included in the MMWR policy note. This table summarizes the dosing recommendations that I just reviewed. The 2 doses at an interval of 0, 6 to 12 months are recommended for persons initiating vaccination aged 9 through 14 years, except for immunocompromised persons. And 3 doses at an interval of 0, 1 to 2, and 6 months are recommended for persons initiating vaccination at age 15 through 26 years, and for immunocompromised persons initiating vaccination at age 9 through 26 years. Now I'm going to give a few case examples that will just illustrate some of the information I just reviewed. The first one is fairly straightforward. A 15-year-old is starting the vaccination series. How many doses does she need? This adolescent needs 3 doses at a 0, 1 to 2, and 6-month schedule. And this is because she's starting the series on or after the 15th birthday. A 13-year-old has a history of 2 doses of HPV vaccine, quadrivalent vaccine given at age 12 years, and 9-valent vaccine given 6 months later. How many doses are needed to complete the vaccination series? In this situation, no further doses are recommended because she initiated vaccination before the 15th birthday and received 2 doses of HPV vaccine 6 months apart. A 13-year-old has a history of 2 doses of HPV vaccine, quadrivalent vaccine given at age 11 years, and 9-valent vaccine given 2 months later. Are any more HPV vaccine doses needed to complete the vaccination series? Yes, although she initiated vaccination before her 15th birthday, she needs a 3rd dose because the 2 HPV vaccine doses were administered less than 5 months apart. I didn't mention this earlier, but the minimum interval is 5 months between the first and second dose, even though the recommended intervals are 6 to 12 months for a 2-dose schedule. And the last case example I have, a 13-year-old received 1 dose of quadrivalent vaccine at age 10 years. Does she need 1 or 2 more HPV vaccine doses to complete the series? This adolescent needs 1 more dose to complete the series because she initiated vaccination before the 15th birthday. She received the first dose more than a year ago, and the second dose can be given as soon as possible. Thank you, and I'll be happy to take any questions at the end of the webinar.
Excellent. Thank you so much, Dr. Markowitz, for that very informative presentation. So far we have 15 questions, so yeah, there's going to be a few questions at the end of the webinar for you. So next on the docket we have Dr. Melinda Wharton. She is the Director of the Immunization Services Division here at CDC and NCIRD, and so we're so excited to hear from her. Dr. Wharton?
Thank you. I'm going to be talking for just a couple of minutes about a couple of implementation issues related to these new recommendations for HPV vaccine. But before I do that, I'd like to remind people how we recommend that practices can improve HPV vaccine coverage. We know it's really important that providers make an effective recommendation for HPV vaccination as cancer prevention in a routine way, just the way we recommend other vaccines for every 11 or 12-year-old patient. Another recommended strategy is to assess HPV vaccine coverage for each provider in the office and develop an office-wide strategy to improve it. It's important to engage the entire practice, not just healthcare providers, in committing to improve HPV vaccine coverage, and practices that implement system strategies to improve HPV vaccine coverage can achieve high levels of coverage combined with an effective recommendation from all providers. So here are the system strategies that we know can improve HPV vaccine coverage. Those include standing orders for HPV vaccination at the recommended age of 11 to 12 years in the practice, reminder recall beginning at 11 to 12 years of age, assessing HPV vaccine coverage at every visit and prompting clinical staff to give HPV vaccine at that visit, scheduling a return visit for the next dose before the patient leaves the office, and documenting each dose in the child's medical record and the state's immunization information system. We know from experience both with HPV vaccine as well as other vaccines that these strategies are effective. But these system strategies also highlight some of the challenges we face with updated recommendations, because if we're relying on system strategies to support improved coverage, those systems need to be updated. And that's really been our challenge with this new recommendation, where the issue isn't ordering the vaccine for the first time, finding a place to purchase the vaccine. That's not what the challenge is, because the vaccine's already there. The challenge is updating our systems so that they support the updated schedule. So thinking about those system strategies, these are some of the things that need to be done. Probably most importantly, everyone involved in immunization delivery in the clinic needs to understand the new recommendation. We really rely on the entire staff to support HPV vaccination, so they need to know the new schedule. Standing orders need to be updated to reflect the new recommendation. Reminder recall protocols need to be updated, and perhaps most importantly, clinical decision support or forecasting functions for the assessment of needed immunizations in electronic health records and in immunization information systems need to be updated. And this really is the rate-limiting step for many practices in making this change. The official clinical decision support from CDC should be available pretty soon, but it's not out yet. And so for many systems, I know this is a rate-limiting step. And of course, systems for scheduling return visits for the next dose need to be updated to reflect the new schedule. Thank you.
Excellent. Thank you so much, Dr. Wharton, for that quick overview. So with that, we're going to quickly do some polling questions. We have a bunch of questions from the audience, so we're going to do this as quickly as possible. How helpful was the information presented on this webinar? Very helpful, helpful, neutral, not helpful. I know a lot of information has been thrown out in the last 30 minutes, so we'll let you guys digest and just let us know how you're feeling right now. Excellent. This is very encouraging that we are able to help you guys out with some of this information. And the next polling question, how likely are you to use the information that we presented during this webinar? Very likely, somewhat likely, neutral, and then unlikely. Woohoo! This is very exciting. We at CDC always strive to give you guys the most pertinent information so that you can use it as quickly as you can. All right. So before we get started with the questions, I just want to make a few more announcements. First of all, because we have so much information and this information is obviously very useful to you guys, we will be sending out a PDF of these slides to everyone who registered probably this afternoon. So you guys should have all of this available to you to digest and think through. And so because of that, you'll have the case studies from Dr. Markowitz, which I will say a good majority of the questions seem to be about specific age ranges and then how many doses to give based on that age range and interval. So because of that, I'm going to start with some other questions, and then if we have time, we can circle back around to those. So with that, Dr. Markowitz, we have a few questions about sharing is it okay for others to share the information you put on these slides with doctors in their practice? Would that be okay?
Yes. I mean, after the ACIP vote, the memo was signed by the CDC director, and so these are our current recommendations. So for that reason, it's certainly fine to share them.
Okay, great.
Was that the question about the actual recommendations?
Well, so the trial information you just presented on?
Yes, because the data I presented are in the label, the 9-valent label, and and those are available. And there is a reference on the slide, but all the data that I presented are in the label, the 9-valent label.
Okay, great. And then another general question is, when will the 2-dose HPV vaccine series update be published in the MMWR? Do we know that?
Yes, we are hoping and planning for that to be published before the end of the year, so sometime in December is our current plan.
Okay, great. And then for the trials that you presented on for the 9-valent, can you talk about the duration and who funded those trials?
For the 9-valent trial, the 2 versus 3-dose trial, that was a trial that was done by Merck. And again, it was done in order to be able to submit the data to FDA to be able to have a approval for the 2-dose schedule. There were 5 study groups in that trial, and follow-up to date, and the data that I presented was just from 1 month after the last dose. But further follow-up is planned, and they do plan to measure antibody titers and follow the participants through 36 months after vaccination. But the data that I presented are the data at 1 month after the last dose.
Okay. Thank you. That's helpful. And can you talk a little bit more about the special populations?
Yes. Well, the special population recommendation it's not really changed. We just changed some of our wording for clarification. Because the male recommendation for men is through age 21 compared to women, which is through age 26, which is the upper age for which the vaccine is currently licensed. When the recommendation was made for male vaccination in 2011, it was included in the recommendations that men who have sex with men and men who were immunocompromised, including those with HIV infection, should be vaccinated through age 26. And so that's still our current recommendation here. We've just added to clarify men who have sex with men, including men who identify as gay or bisexual or intend to have sex with men, and also transgender persons. So that was the main change which was in the wording of our special population section.
Okay, thank you so much for that. That's very clarifying. So we have another question regarding, can private providers who deliver VFC vaccine use the new schedule in their practice prior to the release of the MMWR? Is there anything holding them back?
I'll let Dr. Wharton address that question.
Thank you. So this is now an official recommendation, and providers and programs can implement it when they feel like they're ready to do it. As I mentioned, there's actually a number of things that need to be done that, even though the recommendation is an official recommendation, we know that it may take a little while for people to do it. So I'd recommend that programs and practices implement it when they feel like they're ready to do it, and that includes being able to address forecasting.
Awesome. Also, we have another question regarding when will the new standing orders for HPV be updated and be available? Is that something we know, Dr. Wharton?
So in terms of the forecasting and the clinical decision support, that should be available from CDC pretty soon. I think it'll be sometime in the next several weeks, or before the end of the year. But so it should be out before too long.
Okay, and then we have another question regarding, what do we do if our system changes to support the new vaccine schedule? What do we do if it takes over a year to implement? Do you have any insight to share?
Well, that's difficult. I would hope it wouldn't take so long, but I do know that clearly changes need to be made. I think this is one of the reasons that we're very supportive of using clinical decision support as part of registry activities, so that individual electronic health records don't have to update forecasting every time ACIP recommendations change. But clearly those are challenges. There's no doubt about it. So I'm sorry, I don't have a good answer for that. I would just hope that it wouldn't take nearly that long.
Okay. Do we know what the plan is for updating the vaccine immunization sheets for the new dosing schedule?
I expect that there will be an update of the vaccine information statement to reflect the new schedule. But I don't know what the time frame for that is going to be. It takes a little while to get those out.
Okay. Do you have any input or insight as to insurance coverage and when that will change, and only paying for 2 doses for 9-valent at 9 to 14?
That is not anything I've got any insight on. I don't know that insurance companies necessarily would not cover a 3rd dose. And remember that the ACIP recommends 3 doses for even if the child starts the series under age 15, if the intervals aren't appropriate for the 2-dose schedule. So that still would be an ACIP recommendation.
Awesome. Thank you for that. Dr. Wharton, we have another question regarding what is the recommendation for calculating provider-level vaccination rates with the new schedule as far as dosing? Do you have any insights about that?
I'm sorry, could you repeat that question?
Sure. So what is the recommendation for calculating provider-level vaccination rates with the new schedule as far as the dosing is concerned?
So those algorithms will be being developed and as part of our AFIX process, but that work is ongoing. So that's one of those things that is going to follow in the future.
Okay, great. I believe this question is for Dr. Markowitz. There was mention that most vaccines used in 2016 were 9-valent. Can you give us a better sense for the actual proportion?
I do not have those data yet, but I think we would after the data from the complete year are available. Most of the data we have are actually on doses sold or distributed, and by the end of the year, I do know it was over 90%, but I don't know for the entire year.
Okay. Sorry, I'm just looking through the through the questions. Dr. Markowitz, there was a question about why not saying 6 months or more for interval between the first and the second dose. We never advise the need to restart vaccination based on too long of an interval. Do you have some insight around that?
ACIP did consider various different wording for how to articulate the schedule, and most people felt that from a programmatic perspective it would be very good to have a specific interval, and the studies were done at the 2 intervals, 0, 6, and 0, 12 months. One could make the same statement for the 3-dose. We say 0, 1 to 2, and 6 months, even though the schedule does not need to be repeated if the 3rd dose is delayed, for example. But I think from programmatic perspective, it's very good to have an interval where that indicates, where how we want vaccination to occur. And I think to have it open-ended would be a confusing message and hard for people to actually implement that.
Okay, and then here's another question regarding age. If the study shows that immunogenicity is better if the vaccination occurs earlier, why isn't ACIP lowering the age recommendation to 9 years old?
Well, currently we do say, and I think I did read that, it was on one of my slides, that the target age is 11 to 12 and vaccination can be started at age 9. So that is currently a provider that wants to start the vaccination at age 9 can start at age 9, and we know that some people are, but our target age group is 11 to 12. And I wanted to say that we know that the antibody titers are higher at younger age groups, but the difference between them at 9 versus 10, 11, or 12 is not great. And we also know that even though these antibody titers are higher, it doesn't mean at that age that higher necessarily means it's better.
Okay, great. So Dr. Markowitz, have the minimum intervals changed at all for the 3-dose series?
The 3-dose series we have changed the minimum interval as it's been compared to what it was stated before. In the past, we had stated that the minimum interval was 24 weeks, and based on data in the label, we've now have the minimum interval at 5 months between the first and the last dose for both the 2 and the 3-dose schedule.
Okay, and then we have a few more questions about why is there no recommendation to revaccinate with 9-valent if patients have already received 2 quadrivalent vaccines?
We currently do not have an ACIP recommendation for additional vaccination with 9-valent vaccine. ACIP has not formally considered this, and it's currently not. There's not a recommendation for that. There's not a recommendation against it, but it's not currently one of our ACIP recommendations.
Okay, great. And can you reiterate one more time, why is the cutoff age 15 years old?
Yes. So the studies that were done to look at whether 2 doses of HPV vaccine were non-inferior to 3 doses of HPV vaccine in the age group in which efficacy was demonstrated in the clinical trials, those studies were done looking at 9 to 14-year-olds, and the comparison was the antibody titers in 9 to 14-year-olds compared to women in the older age group. And those studies have not been done above age 14. So we don't have data on that older age group. It's not to say that those data wouldn't show something to indicate that it might be, but right now we don't have those data. And we do know the antibody titers, the antibody response to vaccination is lower as the age increases. But the studies that have been done to date with the bivalent, the quadrivalent, and the 9-valent vaccine have all been done in adolescents through 9 to 14 or even younger age groups. So we don't have data to address that particular question in individuals 15 years of age and older.
Okay, and then can we talk about what happens if physicians still have quadrivalent vaccine on hand? Can they still use the quadrivalent vaccine they have in their office?
Yes, they can. We know that there is some quadrivalent vaccine out there, not that much, but we do know that there is some quadrivalent vaccine still in offices, and it can be used. Melinda, I don't know if you have any comments on that.
Well, given that the additional benefit of the 9-valent vaccine over the 4-valent vaccine is greater for women than it is for men, I think that during the transition we were suggesting that providers might want to think about using the remaining stocks of quadrivalent vaccine in boys rather than in girls. I think that might make sense to do, but again, I don't think there's much of it that's still out there.
Okay, that's helpful. Melinda, I'm not sure if you can answer this question, but what can we do with the NCQA and the HEDIS measures following the 3-dose series for the 2017 year? Do you have any insight around that?
Yes, and thank you for asking that. This definitely is something that we've been working on, and an important thing about HEDIS measures is that for HEDIS 2017, which will be based on the recently approved adolescent measure, which is 3 doses of HPV vaccine for girls by the 13th birthday, along with the other recommended adolescent vaccines, 3 doses along with the other recommended adolescent vaccines, not just for girls. That data collection is really during calendar year 2016. So with this recommendation coming at the end of the calendar year, having that HEDIS measure still be for 3rd doses should not make much difference. And by the time we're talking about data collection during 2017, there will be a chance to update that measure, we expect. So I think that the timing will work out reasonably well to align the measures with actual clinical practice during calendar year 2017.
Excellent. And I'm not sure, we have other questions regarding the CIIS and when that will be updated with the current recommendations. Is that related, or can you answer that?
I'm not quite sure what that means, whether that's asking about the forecasting algorithms and clinical decision support. And again, this should be out soon. I can't put a particular date on it, but it should be out soon.
Okay, great. That's helpful. Also, a question about, are all or any of the HPV vaccines covered under the VFC program?
I'm sorry, could you repeat the question?
Are all and or any of the HPV vaccines covered under the VFC program?
So all 3 of the vaccines have been included in the VFC program for VFC eligible children, but as Dr. Markowitz noted in her presentation, there's currently only one of them that's being distributed. I do have an update on the vaccine information statement, so we do expect to have an updated one out very soon in response to that earlier question.
Okay, excellent. I think, Dr. Markowitz, can you talk about one more time why the HPV vaccine is recommended for women at 26 and then only for men up to age 21?
Well, in 2011, when ACIP was considering the recommendation for males, and as many people know, that the vaccine was first licensed in females because the studies were not yet completed in males to see if there was efficacy against precancer lesions in males. The vaccine was first licensed in females, and then it was licensed in males. And after that time, ACIP considered vaccination recommendations for males. And one of the things they considered was the burden of disease in males and the cost effectiveness in males. And after considering all of those things, and I think it's also people know that as you increase the age of vaccination, the impact and the cost effectiveness decrease because people are already have been exposed to HPV, and so the vaccine is not therapeutic. It works in people who've not been exposed to those particular types. And so based on some of the data that was presented, ACIP decided to make the recommendation for males only up to age 21 because it had less impact and was less cost effective at older ages. And that's how that different age cutoff occurred.
Okay, thank you so much for that. So it looks like we are about out of time. Apologies to everyone who we didn't get to your questions, but we definitely have these questions logged and we know who submitted which questions, so we'll be happy to get back to you individually when we have had a chance to answer those questions for you guys. So a big thank you to all of our presenters today, and thank you to everyone again who's participated. We had a good-sized crowd today. Please feel free to send any additional comments or questions or anything after you've digested all this information. If you'd like to reach back out to us, our email is preteenvaccines@cdc.gov. We welcome anything you have to say. And again, these slides will be available to everyone who has registered, if not today, definitely early next week. And then we will let everyone know when this will also be, this has been recorded and will be posted as well. So thank you so much. Have a great day, and we'll talk to you later.